السلام عليكم ورحمة الله. رب اشرح لي صدري ويسر لي أمري واحلل لي عقدة من لساني يفقه قولي. I would like to start by thanking the organizing committee for this kind invitation to participate in this rather interesting, ill-studied topic from an ophthalmology point of view, I must admit. And it's an eye-opener for me, and I'm sure for my fellow ophthalmologists, that this is a topic that we really have to investigate further. So I have no financial disclosures in this topic. Just going to focus in my talk about a quick review on the normal anatomy of the retinal vasculature and how diabetes can affect the retinal capillaries and how it causes diabetic retinopathy and diabetic macular edema. And also then move on to the effect of fasting and what evidence that we have in the literature, in addition to the generous evidence that have been provided with from Dr. Mohammed Hassanain and Dr. Bashar Effendi. So going back to the anatomy, just to focus on the retina, is the film of the camera that lines the inside wall of the eye. The general retina is supplied by the microvasculature, and the center of the retina is what we call the macula, and this is the center of vision. And when we look at a cross-sectional analysis, the retina is composed of 10 layers, including the photoreceptors, which are very important for capturing images, then sending it up to the brain through the optic nerve to see. We do have the technology now to, through an infrared light scanning, we do what we call an optical coherence topography, that we take a cross-sectional image of the macula, which is the center of vision, stratifying the 10 different layers of the retina, as we can see in the scan here. And this is a normal scan. We also have the technology to study the microvasculature of the retina, looking at the superficial vascular plexus, the deep vascular plexus, and then the capillaries. And this is a combined technology between infrared and B-scan, where we can actually look into the microvascular component and supply to the retina in general, but in particular to the macula, which is the center of vision. When we look at the pathophysiology of diabetes, as we all know, it is a systemic microvascular disease. And what happens in the retinal capillaries happens to all the microvasculature across the body, where we have an oxidative effect, when we have an oxidative stress that leads to damage to the pericytes and the endothelium of the capillaries of the retina. And this leads to, number one, reduction in the blood supply to the retina, so that's ischemia or hypoxia. The second thing that will happen, that there will be some leakage of the intracapillary components into the macula, causing what we call macular edema. If you look into the microflorimetry here, all these white spots that we see on the retinal blood vessels are actually white blood cells extravasated from the retinal capillaries. So to summarize, we do have hyperglycemia with an oxidative stress and other factors causing vascular dysfunction, increasing vascular permeability, and a breakdown in the blood-retina barrier, leading to ischemia or hypoxia and leading to leakage. Hypoxia and ischemia will eventually lead to the changes to a various degree of diabetic retinopathy, as we know, with mild, moderate, or severe, or progressive diabetic retinopathy, and leakage will lead to what we call diabetic macular edema. There is a cascade of molecules being involved in this process. Some of them are inflammatory, some of them are vascular driven, from ICAMs to MCP, interleukins, 1 to 6, 1 and 8. These are more of an inflammatory. We usually treat these with steroid implants. And the other factors like placenta growth factor, vascular endothelial growth factor, and angiotensin II, they are treated with anti-VEGF. These are the treatment modalities that we use for managing diabetic macular edema and sometimes diabetic retinopathy. So we know that we have mild, moderate, severe, and progressive diabetic retinopathy. We also know that we have diabetic macular edema, and this is how this will affect the vision and lead to loss of sight. So just some images and examples of mild, moderate. These are the fundus photographs that are usually taken into the screening clinics. And based on this categorization, the patients get referred to the eye clinic. And we will be talking a bit more about the importance of screening program in a second. So it's mild, moderate, severe. This is a proliferative diabetic retinopathy. We have a huge circulation of abnormal blood vessels there that it can lead to either bleeding or either fibrosis and detachment of the retina. And these are more advanced cases that we don't really like to see in our clinics. Now, the whole idea is that we want to prevent these. We want to stop them. When we study the blood vasculature, we can also assess the degree of ischemia or hypoxia to the retina. And in the presence of new vascularization, as you can probably see on the bottom right-hand side there, this is just a magnified image of an abnormal blood vessels. And these cases, they usually get treated with laser or PRP, pan-retinal photocoagulation. And this is a normal OCT scan on the bottom right and an abnormal OCT scan on the bottom left, where you can see the diabetic macular edema studied on the scan. Going back to the literature, there was a lot of evidence studying the effect of intermittent fasting on diabetic retinopathy, and there is some evidence on fasting Ramadan and its effect on diabetic retinopathy. But none of these studies have actually looked into data and percentages of patients as we have done here in the DAR analysis, which is a brilliant study that I think that should trigger a lot of more studies to come from an ophthalmology point of view, at least, in comparison to what you've done. But most of these studies, as I said, they were looking into the pathophysiology and how does it affect diabetic retinopathy. And we know with intermittent fasting in particular, fasting will reduce the sympathetic tone, increase the parasympathetic tone, increase the vagal stimulation, increase insulin sensitivity, leading to vascular dilation, reduction in blood pressure, will improve in probably diabetic control, not necessarily having a big role on weight loss. But that's intermittent fasting. Ramadan fasting, I don't think, as we have seen previously, doesn't really have much of an impact on weight loss, because it depends on what the patients eat after they break their fast. But with intermittent fasting, it's a lifestyle. So you do work hard to control the weight. So there's so many cascades of inflammatory reactions being triggered. The most important, or one of the common ones, is the positive serotonin pathway, where it has an anti-inflammatory and anti-new vascularization process. Eventually, hopefully, it leads to the reduction of progression and even sometimes resolution of diabetic eye disease, as I will show in two examples. One of them is a courtesy for one of my colleagues, Dr. Rajapal in the States, and another case is one of my patients in my practice. This is a patient who has had diabetic macular edema. They were treated for diabetic macular edema as per ophthalmology practice with antivascular endothelial growth factor intravitreal injections with limited response. The patient has disappeared for about 6 months, and he started on intermittent fasting. Patient comes back again with resolution of his diabetic macular edema without any treatment. So it really does help, and it really does work. It is an eye-opener, and this is a patient from my own practice. Now, I say golden window here. When I get a patient who is not very well controlled with an HbA1c, let's say for 7, 8, 9, and they have a diabetic macular edema and a reasonable vision, I usually explain to the patient the pathology, but I say, look, this is your opportunity now. There is a chance that this disease can get better on its own if you're working on your blood sugar control, if you're working on your weight, we avoid the treatment that you need, which is an injection every month for 3 months and up to 6 months. So it's a big commitment on the patients, and it's a huge treatment burden. So I saw the patient in September 2019. We discussed it. I gave him 3 months. He worked really hard. Vision started improving. Macular edema started improving. And then he continued on the intermittent fasting. During the first 3 months I saw him, it was Ramadan period. So he also fasted Ramadan. And that has given a bit of a positive effect as well. And his macular edema fully resolved. Now, when we go into the DAR guidelines that you've kindly provided me with, I've looked into the diabetic retinopathy group. But you do have, guys, your kind of scoring system and the risk calculation score, which I honestly didn't know about until Dr. Mohammed has provided me with this. And you also have your, categorization of low, moderate, and high-risk cases. So where does diabetic retinopathy fit into this scoring system here? And when I looked at the data, I'm sorry, I didn't extract any data on separate slides. I just wanted to present it as it is and highlighted the points that I wanted to mention, because there are some points that I found them very interesting for me, and they will help me pass on some messages also to my colleagues in endocrinology department and other departments. What can we do together from your side to help me and help the patient not lose vision? So we have seen that the rate of diabetic retinopathy based on this data actually doubles every decade. So every 10 years, the percentage of patients with diabetic retinopathy is doubled. And that's a bit worrying. But what's really important here, that if you look at the data, the patients who's had diabetes between 10 and 19 years, having had a proper screening program in the first 10 years, maybe would have had a positive impact, lowering the percentage of patients who've had diabetic retinopathy in the second decade. And as the data has come from third world countries, most of it, probably they do not have a well-established screening program as we do have in the UK, for example, which, triggers the importance of we really need to have a screening program in every diabetic center if possible. Another point is, as we know, there is a direct relation between HbA1c and diabetic retinopathy, as we said, probably suggestive of lack of screening or lack of control. Over the age of 60s, 50% of the patients have had diabetic retinopathy, which creates a huge treatment burden for ophthalmology clinics and all the other clinics. On an audit that we've done previously, the number of clinical visits that diabetic patients come to the hospital for, it's probably about 180 visits in between endocrinology, cardiology, podiatry, neurology, nephrology, and ophthalmology. So it is a multidisciplinary disease. Another important point here, amongst the medications that the patients have been on, it's sad to say that I've not seen fenofibrate on the list. As an ophthalmologist, I would love to have these patients being on fenofibrate. We know it's an anti-hyperlipidemia medication. It does have an anti-apoptosis effect and an anti-inflammatory effect. And there is 2 reliable studies that have been done before, the Atwood and Field studies that have actually looked into the effect of fenofibrate on diabetic retinopathy, either on its own or in combination with statins. And I will mention at the end, but it did really have a huge impact on the progress of diabetic retinopathy and macular edema. So I would encourage my colleagues from the endocrine departments and other units, if they could start patients on fenofibrate and it's safe to do so, which it didn't really show in these studies that it has a higher risk than atorvastatin alone, then please do so. From an ophthalmology point of view, I'll be very interested to look into diabetic retinopathy and the GLP-1 agonist. It's becoming more popular now to use, and I think it's worth for me to look into this data. Patients in insulin have done worse. So a high percentage of patients who have diabetic retinopathy are on insulin, which I think is a similar group study as Professor Malik has shown. But most of the patients on insulin have higher percentage of diabetic foot. So is it because that they've not been well controlled on oral medication, they shifted to insulin, it's just a long-term effect of diabetes? Or is it just insulin that's not really helping us control the disease? We don't know. Diabetic retinopathy is a complication of diabetes, but it's not on the scoring system, unfortunately. So I think it's something that we probably need to add to the risk calculation risk. Less patients in the study, about 77% of patients managed to fast. 77% of patients with diabetes or diabetic retinopathy managed to fast in comparison to 90% other group. Worth mentioning that patients who've had hypoglycemia, about 21% of them had hypoglycemia during Ramadan. 21% of patients with diabetic retinopathy had hypoglycemia during Ramadan. So yes, from an ophthalmology point of view, I do like my patients to fast, But on the other hand, we don't want the patients to have hypoglycemia. So it's a catch-22 really. Just a brief sum of the Atwood field study, which I think is really important message to take. 40% of our diabetic patients.
1 minute.
40% of our diabetic patients coming to the eye clinic will need laser. 40% less patients will need laser treatment for diabetic retinopathy, proliferative diabetic retinopathy. So it really does have a positive impact on the progression of diabetic retinopathy phenofibrate. So I would really strongly suggest using it. In summary, fasting does have a positive impact on reduce the progression of diabetic retinopathy and even the resolution of diabetic eye disease. Phenofibrate will help, reduces the risk for laser treatment about 40%. Higher percentage of patients are on insulin. Diabetic retinopathy is higher and associated with or preceded by other complications. So the majority of the patients will have other complications, hypertension, hyperlipidemia, and the rest of it. I think it's recommended that it's added to the calculation risk. Maybe it should even add a minus point rather than a positive point to the calculation risk. I would like to encourage the patients to fast rather than not fast, whether it's Ramadan fasting or intermittent fasting. And that's all from me. Thank you so much.